Okay. Good evening to all. Thank you for choosing to attend this webinar today. I am Anand from TESCON, Bangalore. TESCON has been part of the aerosol research community of India for the past 25 years or so. We have supplied and maintained premier research instruments for various research groups in India and other neighboring countries. Our major contributions have been in the field of atmospheric research sciences, air pollution measurement mitigation, and so on. Today, we will be focusing on high efficiency detection of airborne virus using condensation growth sampling method. There's a lot of news in the recent past about the possibility of the airborne transmission of novel coronavirus. Even on Tuesday, a group of 239 scientists from various countries, to be specific from 32 countries, had penned a letter to WHO outlining the emerging evidences on the airborne transmission nature of coronavirus. In this context, we have with us today Pat Caddy, the president of Aerosol Devices, based in Colorado, USA. She'll be talking in detail about the sampling method of airborne viruses. If you have any questions during the session, you can post a message in the chat box. We'll try to answer your questions at the end of the session, or else we'll be in touch with you personally after the session. Yeah, over to you, Pat.
Thank you very much, Anand. I really appreciate that all of you have joined me today because I'm excited about sharing our story about bioaerosol sampling, as it may have a profound impact on health, especially today as we are learning more about airborne transmission of the SARS-CoV-2, the virus that causes the COVID-19 disease. So the problem is that breathing airborne viruses and bacteria can make you sick, but how do you even know that they're there? The way that we monitor the spread of an infectious airborne disease is we first wait to see who gets sick, then we put a dot on the map and we watch as the dots move around the world. But these are not just data points, they represent real people, and maybe it's your son or your mother. But because people can be contagious long before symptoms appear, or they may always remain asymptomatic, yet be capable of shedding the infectious virus, so the threat is present even before we know about it. Our highly mobile society means that thousands of people can be exposed in just a few days. We are essentially blind to the biohazards that exist in the air that we breathe. This method of biosurveillance is far too passive and too late. Wouldn't it be better if we knew when we were exposed to a pathogen before we get sick and have a clinical diagnosis? Aerosol transmission of the SARS-CoV-2 virus remains controversial and very scary to many people. The World Health Organization and the U.S. Centers for Disease Control have maintained that you have to worry only about two types of transmission: inhaling respiratory droplets from an infected person in your immediate vicinity, or less common, touching a contaminated surface and then your eyes, nose, or mouth. WHO officials have acknowledged that the virus can be transmitted through aerosols, but they say it only occurs during medical procedures such as intubation that can spew large quantities of the microscopic particles. In the past, they said that all of the evidence that's been presented by Lydia Morawska and others have been based on laboratory experiments rather than evidence from the field. And so while they value their opinions, a large group of more than 30 international experts advising WHO have judged that the existing evidence is not sufficiently convincing to consider airborne transmission as having an important role in the COVID-19 spread. But, she added that the transmission would have resulted in many more cases, even more rapid than the spread of the virus is occurring today. But when scientists say that there is no evidence, sometimes it's because the evidence is genuinely hard to collect. So let's first take a look at some of the evidence that does exist. You're probably already familiar with some of the early news and publications describing significant outbreaks that took place in cruise ships, restaurants, and in a church choir practice. Recently, there are many, many more outbreaks occurring in prisons, bars, meatpacking plants, weddings, pretty much anywhere that people gather, mainly indoors, and spend a significant amount of time together. More anecdotal evidence has come up when doing sampling in hospitals, and they have found viruses on the air vents, in a nurse changing room, and in hallways outside of the infected patient rooms. So while the presence of the virus suggests that it may be transmitted by air, there still is no direct evidence of the airborne virus infectivity. But just yesterday, as Anand alluded to, the WHO is now paying attention to airborne transmission as a possible method of the spread of the disease. And just yesterday, they added this paragraph to their website where they're stating that aerosol transmission cannot be ruled out, but that more studies are urgently needed. This is a really important recognition that we need to pay attention to. So what is an aerosol? This should be a really easy answer, but it gets complicated. Aerosols are liquid or solid particles that are suspended in air, typically sized from 1 nanometer up to 100 micrometers. They can be visible like fog or invisible like viruses and bacteria. So the occupational exposure community has defined biologically relevant particle size fractions based on their relation to the human lung deposition data, as shown in this chart. These definitions have been standardized by the ISO and ACGIH, a US organization. So inhalable particles are those that deposit anywhere in the respiratory tract, mainly in the head and throat. Thoracic particles penetrate beyond the larynx into the upper airways of the lung, and respirable particles penetrate deepest into the lung, into the alveoli, the gas exchange region. So also shown on this chart are commonly used environmental definitions classifying particle sizes. PM10 and PM2.5 are all particulate matter smaller than 10 and 2.5 microns. PM10 is also called coarse particles, and PM2.5 are fine particles. And you can see from this chart that PM10 closely matches the thoracic curve. The PM2.5 size was chosen because there's a natural dip in the size distribution of atmospheric particles, separating the accumulation mode and the coarse mode. You also will hear PM1 and PM0.1, as these have gained more attention in recent years. These ultrafine and nanoparticles are abundant in the total number and may have even stronger health effects than either PM10 or PM2.5. Ultrafine particles are the nuclei mode. So none of these commonly used size particle fractions are used by the medical community. According to WHO and CDC, infections are transmitted by particles larger than 5 microns, and these are called droplets. And infections transmitted by particles 5 microns or smaller are considered aerosols. And this definition goes way back to the 1930s. Large droplets can quickly fall to the ground, whereas smaller aerosols can stay afloat much longer and be transported much further. In reality, there is no such clean break between aerosols and droplets, as there is a continuum of sizes, and their behaviors in the air gradually changes as the particle size changes. So particle size matters, as it will determine how deep a particle can deposit in the respiratory tract and how it will behave in the air, including how easily it is to filter with a face mask. So when we say the term aerosol, we do not have a common language. Seeing the bright sides of the COVID-19 pandemic, one aerosol scientist said to another, well, at least now people won't think aerosols are just spray cans and graffiti. And the response was, yeah, now they'll think aerosols are viruses. So it's a challenge even in understanding what we mean when we say aerosols. So looking at some of the previous work that shows evidence of transmission through aerosols, this is a chart showing, or a graph showing, particles expelled from a sneeze. And you can see with the laser imaging that they don't transport just 2 meters, but can go 7 or 8 meters. And this is from coughing or sneezing, but particles can also be expelled by talking, singing, and just breathing. And as I said before, they travel much farther than 2 meters. Asadi in last year published a paper where they introduced this concept of super spreaders. These are people who can be especially good at exhaling fine particle material, producing thousands times more than other people. And pre-symptomatic and asymptomatic cases are considered stealth spreaders. So people can emit these particles, and these particles can contain viruses. Some work by Don Milton and Cowling and others have shown viable influenza particles in these emitted particles from the human respiratory tract. So another piece of evidence that we have is that masks work. And there was a recent illustration of this where a doctor, on a very simple experiment, was just putting a petri dish in front of his face. And he was wearing a mask and then not wearing a mask and doing several different things: sneezing, coughing, singing, and talking. And you can see on the petri dish the incubation of bacteria, the viable bacteria that was found on these petri dishes when a mask was used and when no mask was used. And it's pretty striking to see just how many bacteria were collected from this otherwise healthy person. Now, there are some issues. I want to just point out that this is bacteria, not viruses, and that by just looking at what settles on a petri dish, we'll only collect large droplets and not particles smaller, which also can contain the virus. But it is a striking image. At first, the WHO and CDC said that masks were overkill for ordinary people and should only be considered for health workers. Later, the CDC recommended masks only for people with COVID-19 symptoms. Then in April, after it became clear that people without symptoms could also spread the virus, the CDC suggested masks for everybody when physical distancing was difficult, a position that the WHO eventually adopted in June. But which masks work best? You can see here we have from the best to the worst. The best is a powered air purifying respirator, and this is what firefighters use. Better is an elastomeric face mask with a cartridge filter. These are high efficiency and have great sealing on the face and are used for dangerous occupational exposures. A good mask is the N95 or the FFP2 filtering face pieces. These are also fit tested and are what medical doctors and nurses typically use. So a fair mask are these surgical masks or homemade masks that remove large expelled droplets, but are not fit tested. They're not sealed to the face. They do offer protection, mostly for the protection of others, but can still offer some protection to the wearer if worn correctly. And you can see in the little diagram on the left, this is the incorrect way to wear a mask over the eyes. So the poor or the worst choice is to not wear a mask at all or to wear your mask incorrectly. And I'd love to be able to share with you today the video that I have linked or put on this slide, which is a very simple and accurate description of how an N95 mask works. And I highly recommend that you take a look at it at some point, especially if one you want to share with your non-scientific friends. Here is another link that I just wanted to make you aware of. There are many, many scientists who are doing theoretical modeling, theoretical work to describe airborne transmission in various indoor settings, and this is probably one of the easiest. It's a spreadsheet where you can predict the transmission in classrooms, buses, and so on and so forth. Again, we're not going to go through it, but I wanted to give you that information. So the evidence that's still missing about the airborne SARS-CoV-2 virus is we don't know exactly what the particle size distribution and viral content is from the exhaled breath. We don't know if there are multiple virus particles per droplet. Are there a significant number of submicron particles? And just what makes a person a super spreader, and what sort of activities generate what size particle and the most particles. So there's a lot of questions about just the source of these virus particles coming from human transmission. The next question is about viability of the airborne viruses. Just because they exist in the air, if they're not viable, they don't really pose a threat. So we need to understand more about the infectious or the viable nature of these viruses and how they are affected by environmental conditions, for example, temperature or relative humidity or the light, and just how long they stay viable and as a function of time. The third is airborne transmission and where these particles transmitted. It's a very complex thing because it depends a lot on the airflow within the building, the HVAC system. But how long do they stay airborne, and what is the exposure to people within the same indoor setting? Fourth, we have the dose response. We still don't know how many viable virins can cause a disease, and what is the incubation period. In fact, I've heard that we don't even know this yet for influenza, so that's how difficult this is. Finally, viral shedding at various stages of infection. When are people most infectious to others? Is it 2 or 3 days before they get symptoms, which is widely believed today? And can they still be shedding after they've gotten symptoms? So there's many, many questions we still don't know the answers to. Knowing the answers could lead to more effective non-pharmaceutical inventions, things like engineering controls, having better ventilation and physical barriers, and so on. Social distancing, there's controversy over whether 2 meters is enough. Some countries are moving to a 1 meter distancing. As we saw in earlier slides, I'm of the opinion that 2 meters is far too close and that we need to have much greater distancing, but this may not be practical. And then making sure that everybody is wearing face masks, even the homemade cloth coverings, as these can at least help reduce the risk. So we're blind to these biohazards in the air we breathe, and that's the real challenge. Because we can't see them, people think it doesn't exist, or they have lots of questions, and that's understandable. The problem is that monitoring airborne pathogens is challenging. Bioaerosols are difficult to sample, and here's a number of common sampling methods, many that you may have used yourself. Traditional sampling methods like filtration, impingement, or impaction are very old technologies and are generally inexpensive, but they also have many deficiencies. The most serious is that they have a size-dependent collection efficiency, and they generally produce very dilute samples. They're prone to contamination, and because of all of these challenges, there really are no regulatory standard methods for how to collect airborne particles that are bioaerosols. Very often, the sampling process itself can damage the microbes and kill or inactivate the microorganisms you're trying to evaluate. And this is because of desiccation from filtration, let's say, or impaction. There's mechanical stresses, or they can be subjected to thermal shock. So even if they were viable in the air, the act of sampling them may end up, in fact, inactivating them. So we have a new approach for sampling aerosols for biological analysis. It has high collection efficiency over a very wide size range. We concentrate the sample. We can have time-resolved sampling. The sampling technology can maintain the viability better than other sampling methods. And we can also have instant genomic preservation of the DNA and RNA. And right now we have two instruments that are really geared towards research. And the main differences between the two are the flow rate. The spot sampler is a 1.5 liter per minute flow rate. And the BioSpot Vivus bioaerosol sampler is 8 liters per minute, which is approximately the volume or the rate of breathing. So our new sampling approach uses the method of condensing water vapor onto small particles to form a little fog of microdroplets. And the water blanket that surrounds each of the particles provides a hospitable environment and then allows gentle, stress-free sample collection that interfaces with a wide array of analytical approaches. A little brief history on water-based condensation particle growth. This was first introduced in the mid-1990s, but all of these methods mixed steam into the airstream and then cooled. And so these methods subjected the sample to very high temperatures, which is not something you would want to do when sampling bioparticles. And in 2003, Suzanne Herring introduced a technology that allows particle growth through laminar flow water condensation. And basically going from the left to the right, you have aerosols subjected to a cool environment in a wet walled tube. And then it's heated. And what happens is that the water on the wick, on the walls, evaporates into the airstream with higher diffusivity, a higher rate than the thermal diffusivity. And so you get more water entering the airstream than the air can actually hold. And so this is an unstable situation. And so to reach equilibrium again, this water vapor has to go somewhere. And that's where it condenses out onto the seed nuclei particles and rapidly grows them into larger droplets. Now, one of the problems with this is that at the exit of this droplet growth tube, you still have a relatively warm, high humidity environment. So a new design was introduced in 2014, which added a third stage, a moderator stage. And in this moderator stage, it's once again cooled. The droplets continue to grow, but simultaneously, water vapor is removed to the walls. And so you're lowering the dew point. And at the exit of your growth tube, you still have your droplets containing the bioparticles, but you've reduced the humidity so that you don't get excess condensation downstream where you don't want it. So this shows the growth tube with the droplets then being collected into a liquid sample, a very small volume of liquid, about 0.5 milliliter of liquid. We can collect these droplets, so you get a very concentrated sample. We can also collect these droplets onto a solid surface and evaporate the water off, and what you're left with is just a single impaction spot of all the particles that you have sampled. So the modeling shown in the center here, we can show the temperature. Let's see. So the temperature within this growth tube is moderate. You don't have steamy high temperatures. And in fact, they're very similar. The maximum temperatures are very similar to what is in the human lung. And the exit low flow temperature is then around 18 degrees C, and the dew point is below 20 degrees. So supersaturation levels at the peak in the growth tube rise to about 140%. And this activates condensation on particles as small as 5 nanometers. So we're able to uniformly grow particles that are very, very tiny up to sizes that can be easily collected. Droplets grow to a nominal 3 micrometers and are collected into solid or liquid surfaces, as I mentioned before. So the collection efficiency, which with the condensation growth tube collector, you can see we get very high, close to 100% collection efficiency over all particle sizes greater than 5 nanometers. And we've tested it up to about 10 micrometers. Compare this to some of the commonly used bioaerosol samplers using just inertial collection. The SKC biosampler is an impinger, and you can see that it works pretty good down to about a 0.5 micron, but below that, it's just not able to sample those particles. A wet weld cyclone has an advantage of having a very high flow rate, but as you can see, it is even more limited in its collection efficiency. So testing results of the condensation growth tube. Here is a test with an MS2 virus aerosol that was laboratory generated. And we're sampling with both the condensation growth tube sampler and then the SKC biosampler. Now, MS2 particles are relatively small. They're about 30 nanometers. And so you would expect that the impinger, the SKC biosampler, would not have very high efficiency, whereas the condensation growth tube has about 10 to 100 times higher collection efficiency. Now, this is just the physical collection efficiency within the sampler. When we're looking at viability, which is the other thing we want to ascertain, is whether or not you can recover viable microbes. This is a chart showing infectious viable H1N1 influenza virus aerosols that were also generated. And you can see the number generated versus the number of viruses collected. With the condensation growth tube, we get near 1-to-1 collection with the condensation growth tube, whereas with the SKC biosampler, we have about an order of magnitude lower collection efficiency. Now, the important thing to point out here is that the virus aerosols from influenza are much larger. They're about 100 nanometers in size. And so we would expect the impinger to be a little bit better, but still we show quite a bit reduction in recovery as compared to the condensation growth tube. And this is just some of the data. With the condensation growth tube, we see about a 74% recovery from all the different runs, compared to with the biosampler, only a 5.6% recovery of the infectious influenza. This has also been tested with bacteria and yeast. Bacteria and yeast are going to be even larger in physical size. But here again, we still see a reduction in sampling efficiency with the biosampler compared to the condensation growth tube. And it's about a 3-time factor between the two instruments. Another recent development is this sampling directly into a genomic preservative. This is a material that's readily available from the Zymo company. And the chart on the left is showing the recovery. This is genomic recovery of bacteria when sampling either into a solid capture, into a coupon that's been pre-soaked with this genomic preservative, versus into a liquid, the liquid being 100% of this genomic preservative. And on the left, you can see 3 different tests at different sampling times, and you get no statistical difference between solid capture or liquid capture when capturing into this genomic preservative. And the reason why this is important is that sometimes sampling into liquids can be challenging from a practical point of view. You have to, handle a liquid and make sure you don't spill it. Whereas sampling into a solid coupon makes the logistics somewhat easier. The chart on the right shows sampling into a genomic preservative with the growth tube and without the growth tube. And by with and without, I mean it's still going through the growth tube, but the growth tube had no water wetting the lining, the wick, and no temperature changes. In other words, if this sampling into a genomic preservative is such a great idea, why don't we just impact directly into the genomic preservative and not have this growth tube in between? And you can see the difference here around an order or a factor of 2, better genomic recovery when sampling with the growth tube as opposed to without the growth tube. So bioaerosol sampling and analysis, we can collect samples very gently. It maintains viability, maintains the genomic preservative, and that allows for a wide array of analytical techniques. And many of these are being used for various applications. But culturing, there's been certainly microscopy techniques, and the classic genomic sequencing or qPCR are the most commonly used for bioaerosols. But we're also working with some people to be able to take our samples to do a MALDI-TOF spectrometry or a Raman spectrometry to be able to analyze these particles. So the collection doesn't really care what the analysis is. It's just providing a higher quality sample. So some of our early adopters were looking at disease transmission routes and sampling pathogens in environments as diverse as swine barns and a hospital operating suite. And most of these users are now sampling the SARS-CoV-2 in a variety of settings. And we're still waiting to see some of the publications, as many of these projects just got started recently. The FDA is one of my favorite stories because they had stated that they were able to collect live pertussis bacteria, or whooping cough, in a primate study. And they noted that this was the first time that this has ever been achieved after trying for 6 years using other bioaerosol sampling methods. And in fact, they were so pleased with how the sampler was able to collect viable pertussis bacteria that they bought a second unit 6 months later, because they wanted to see how the bacteria could be transported within the room. Many of our customers are now repeat buyers. So I wanted to briefly talk about some future developments. We have recently gotten a new grant from NSF where we are making a low-cost, much simpler sampler for genomic analysis only. And this would expand the areas where this unique sampling technology can be used. In other words, we want people who are not aerosol scientists to be able to collect a high-quality sample. And so our target customer for this would be people in healthcare settings, or public health officials, people in nursing homes, or doing transportation studies, and so on and so forth. So we just got that grant in June, and we're working as fast as we can because we recognize the urgency with addressing this pandemic. We have another project funded by the National Institute of Health where we are integrating our sampler with an electrochemical biosensor. These biosensors are targeted for a very specific virus or bacteria, and the focus right now is on the SARS-CoV-2. But in the future, we could have it be targeted for influenza or anthrax or many other bacteria and virus pathogens. And in fact, the sensor could be multiplex, so we could be looking at more than one pathogen in the same sample. I have a link here to a YouTube video which describes our technology, and if I can get it to work here, I'm going to actually show it to you because it's a fairly short sample, so we'll see how that goes. Okay.
Hi, Pat. I'll share the video of the link on the chat box so that everyone will be able to see that. Yeah, Pat. Thank you for the presentation. We have a few questions here. I'll just try it out. Probably you can answer it. So one is about the diffusion loss. Like how are we getting almost 100% collection efficiency in the smaller size range of particles?
So that's really fundamental question to how the entire sampling method works. The way that we get the high collection efficiency of the small particles is that we're enlarging their size through condensation growth. And so they no longer are being subjected to the diffusional losses that you would normally find in some other sampling methods. And we're able then to, because they all grow to at least 3 microns in size, we're able to easily collect them with inertial sampling into through impaction or impingement into a solid or a liquid surface.
Yeah. So there's one more question about effect of various external parameters such as humidity, temperature on the virus lifetime.
So that's another one of those questions that's not been answered yet about particularly this virus, is just how it's affected by humidity and temperature. There have been some studies in the past by Lindsay Marr looking at influenza. And so this is an area where more research needs to be done. But within the sampler itself, yes, we're subjecting it to high humidity because we're, in fact, condensing water vapor onto it. But the transit time through the growth tube is extremely short, on an order of a second or more, and so it doesn't really have a lot of time to be able to affect the biological particles in the sampler itself. And then we're sampling directly, typically into a buffer, so that the viability can be preserved. But that's a very important question, is just how viruses or bacteria are affected by humidity. And I believe that it's different for different microbes, different viruses. It's not a uniform answer for all organisms. Yeah.
And you were talking about super spreaders. So what makes a person or a source super spreader? Does it have, is there any number that we can associate with that?
So again, that's one of those unknown questions. So what Asadi in 2019 had determined that people are emitting these particles even when they're just breathing. They don't have to be talking or coughing or sneezing. And that, again, some people emit a lot more particles than others. We don't know why yet. One of the advantages of this pandemic is that a lot more money is now being put into research, whereas for many, many years, it was very difficult for these scientists to get funding to be able to do these kind of very complex studies. And so hopefully with some additional funding, that some of these fundamental questions can be answered, not only for this coronavirus, but for all infectious respiratory diseases. So these are very important questions. We don't know why some people are super emitters, but it's been documented that some people do emit a lot more. So I hope that you're one of the groups that can do this kind of study.
Yeah. So coming back to the sampling, so what do you think the advantages when in comparison to other available commercial products, like with respect to the feedbacks from the current users that you would have got?
So this is where some of the early studies have shown and compared with filtration, with impingers, and again, we're continuing to do more studies. But the biggest difference between our sampling and other sampling is two things: the uniform high collection efficiency over all sizes, so we can get submicron particles, the bare viruses, all the way up to the larger droplets that can be inhaled. So the uniform high collection efficiency and the ability, because of the gentle sampling, the ability to maintain the viability, but also, even and more important, is just that we're sampling intact organisms. We don't break them apart because of desiccation or mechanical stresses. And so even if you're doing genomic analysis, we get a much higher recovery because these organisms are not damaged in the process of sampling. And so there's a lot more testing that we want to do, but we don't have publications yet for how these compare to, say, some of the wet welled cyclones, for example. But we have got definite data with filters and impingers that show, orders of magnitude better sampling recovery.
Yeah, thank you. And one more was about newer version that you were thinking about. So when can we expect that one?
I knew there was a danger in putting that slide up there. So we just got the grant, and we are accelerating development as fast as we can. We're engaging some outside resources as well, including a contract manufacturer. We hope to be able to have this available this fall. This is a very simple sampler. It will only sample into a solid coupon that's pre-soaked with this genomic preservative. So it will not be able to get viability, but it will be able to tell you whether or not the virus is detectable, its presence. And that alone could be very helpful in giving people an early warning of where exposure might be. And we hope someday that there are pharmaceutical therapeutics so that if you've been exposed, you can maybe take a drug that would prevent infection. And this would be very valuable in stopping the spread of this pandemic. But right now, today, we don't have that kind of advanced warning of an exposure. We just, like I said in the beginning, we just wait to see if somebody gets sick, and then we react. But then it may be too late.
Okay. So one more question is about, the possibility of detection of genetic variability of COVID-19 virus from the sample material. So is there any studies that you know is going on that way?
The genetic viability?
Yeah.
So yes, most of our customers right now are trying to determine the viability of the airborne virus. One of the things that we have found is that in hospital sampling, for example, in Singapore, they've been sampling in hospitals. Very often hospitals are quite clean. They do a very good cleaning procedure. They have good ventilation. So there isn't a lot of airborne virus available. And only now are people starting to take these samplers into other settings, not necessarily hospital settings, to be able to sample and determine viability. One of the things that we have found with our customers is that they're very protective of their data because they want to be the first to publish, or it's something I understand. Researchers want to make sure that the sampling data is repeatable and reliable before they publish, and they don't want to share their data. So this is a very dynamic, very fast changing situation. We expect publications to come out in a matter of weeks, months, maybe tomorrow. I don't know. This is changing so fast. But we do have about 11 customers that we know of that are actively sampling, and we're getting encouraging words, but no data from them yet. So.
Okay. So one more question is about variability of virus genetic. It's not viability, variability of virus genetic.
And maybe I don't understand the question.
Okay. So it's basically genetic variability. So if you're not able to hear me, probably I'll just mail you the questions.
No, I can hear you. It's genetic variability. I thought you said viability. So
Yeah.
yes, of course. So we're not doing any analysis ourselves, and so the genetic analysis, for example, the qPCR or the sequencing would give you that genetic variability. So we're collecting a sample very similar to a swab that would be collecting a throat sample or a nasal sample. And so yes, the analysis of that sample would be using all the same tools that they're doing with biological samples, with the nasal swabs. Did that answer the question?
Yeah, kind of.
Okay.
So thank you for your time in the session, Pat. So we really appreciate the same. So like if there are any questions and more questions, probably we'll be able to be in touch with you. And
Okay.
the details of the presenter is already in the screen. So you can directly contact Pat as well regarding any queries, scientific queries that you have. Thank you, Pat.
Yes, thank you. I appreciate all the questions and your attention. Have a great weekend.
Yeah, same to you. And thank you all attendees. Yeah.